And I'm going to now invite Dr. Hamid Sharif to talk about role of cardiologists in stroke intervention. So while Hamid is getting his slides ready, so we've acquired this 640 slice ultra-fast CT, and with that we've also acquired, we'll probably be the first center in Pakistan to have artificial intelligence software with it. So that artificial intelligence software is actually going to help us a lot with the case selection. It itself interprets the plain CT brain. It exactly tells you where the vessel is occluded. On the picture it shows you that, and it gives you volumes for penumbra and core and FARC to tell you how much brain is still salvageable and if it is beneficial to perform thrombectomy or not. So it sends all these images onto you, the email addresses of all the on-call team members, and it exactly writes down patient is a candidate for mechanical thrombectomy or is not a candidate for mechanical thrombectomy. So that artificial intelligence actually is going to be quite helpful further onwards for us. Over to Dr. Hamid Sharif.
Thank you, Dr. Asim. So first of all, I'm very thankful to the society for giving me the opportunity to talk on this topic. So as we all know that we are presently in the era of stroke cardiologists, so more and more centers are now coming up with stroke intervention, and I think a lot of credit goes to General Kiani, Sir Asim when it comes to Pakistan, our part of the world, in which more and more cardiologists are now being involved and centers are involved in stroke intervention. So as you all know, the WHO shows that stroke is one of the leading causes of morbidity and mortality worldwide. Approximately 15 million people worldwide suffer a stroke annually. And you all know that approximately 2/3 of them, that is 70% of them, are ischemic strokes. And they are manageable within a time window, as we have seen in the previous slides. Of these, 5 million die. Another 5 million are left with permanent disability. So this is this chunk of people that we are looking at, and we can bring them back to the society, back into the system by doing mechanical thrombectomy as long as they fall in a particular window. So time is brain, as you all know. In each minute, we lose 1.9 million neurons, 14 billion synapses, 12 kilometers of nerve fibers. So this is how the extent of disease. That is why we know as early as possible we intervene with stroke intervention, we can save this problem. The new data analysis of 2015 trials have shown if you can open a blocked brain artery, within 2 hours, the recovery is approximately 90%. And after 6 hours, it is approximately 20 to 30%. So that is the essence, the time is brain. So as early as possible within the window that is 4.5 to 6 hours, we have to intervene and we have to see the benefit in the patient. So mechanical thrombectomy in lytic versus lytic and acute ischemic stroke is nothing new. In 2015, we had a lot of trials, Mr. Clean, Diffuse, Dawn, and all these trials have definitely shown the benefit of mechanical thrombectomy in addition to IV TPA. So now it is almost a class 1 indication when it comes to ischemic strokes, especially in those patients who have large vessel occlusion and those patients who come within a particular window, and if this artery has the capacity, it should be opened through mechanical thrombectomy, either through adapt or stent retriever for that matter. So this is a picture of endovascular treatment scenario in 2020. So after the guidelines came that mechanical thrombectomy is the way forward, in 2020, they saw that in the United States, approximately 834,000 patients had total strokes, and out of these, 87%, that is 726,000, had ischemic strokes. Out of them, the large vessel occlusion, those patients which fall within the window and they could be treated, they were 275,000, and approximately among them, only 9,000 were treated. That is, only 3% of LVOs were treated. That is, 97% of the patients who could be revived, who could have been brought back into the system, they could not be. And this I'm talking about a progressed country like United States in a year of 2020. And only 1.3 devices per patient were used. So the stroke centers in United States, as we spoke of 2020 were 2011. Neuro intervention was 1,200, and they were doing, the burden upon them was 230 neuro interventions per year. And if you look at the same country, they have got 8,000 intervention cardiologists who could share this burden. That is 3% of the whole population, those who have an ischemic stroke within the particular window, they were treated by stroke interventionists. And 97%, a huge burden that was untapped, that could not be treated. So if you look at the European scenario in 2019, these are the different countries, Germany, Portugal, Czech Republic, Northern Ireland, and you can see 52 out of 1,000 patients only in Germany, which had the maximum numbers of stroke interventions being done within the time window. So it was only 52 out of 1,000 patients who could be. And this is the grave scenario. A lot of patients who had the capacity of being treated could not be treated because of the shortage of the neuro interventions in these developed countries I'm talking about. So how can this burden be shared? We can increase the number of neurointerventionists in the stroke centers. Well, it will take decades, a lot of time, if not decade. Other options is that we have 24/7 primary PCI cath labs running in most of the centers, even in Pakistan and all the other countries. And we have almost trained interventions available. That is the interventional cardiologist. So these are the cardiologists with minimal amount of training, as we have seen in the previous slides by different presenters. If they have been given appropriate training, they can definitely share this burden. And they can move forward with this intervention by training other cardiologists as well. So ICs as strokes, that interventional cardiologist stroke interventions, what are the various pros and cons? If you look at the pros, the stroke intervention parallels primary PCI, opening the blocked artery. That is normally we do in primary PCI 24/7. Open the block, for example, on the right side, we can see there is a blocked LAD. And what did the stroke interventions do? They also open up the blocked artery. So there's a lot of similarity. If you look at the treatment over a period of timeline treatment, the treatment of primary PCI, that is STEMI, has paralleled the treatment of the stroke. Initially, it was TPA, both in STEMI as well, streptokinase or TPA. And similar was the case with stroke patients, ischemic stroke patients. And over the period of time, now we all know that we have to open up the blocked artery. In STEMI patients, we normally do it with stents and with balloons. And with empty mechanical thrombectomy, we do with stent retrievers. So a lot of parallel systems going on between the two management plans. So what is the rationale for cardiologist involvement? Number one, cardiology are almost always involved in stroke prevention. Prevention of atrial fibrillation, prevention of hyperlipidemia. So they know what are the causative factors. They can play their role in prevention as well. There's an increased role in carotid disease. A lot of cardiologists are doing carotid intervention, not only in Pakistan, and also doing in United Kingdom and also in states as well. There's catheter and wire skills well developed. They know how to maneuvers between tortuous wire. There's a big difference. We cardiologists work on beating hearts while stroke is different. So mindset is same there, and location where do stroke occurs. There are certain strokes, a lot of strokes do occur within the cardiac setup as well. Those patients who have valvular heart disease and those patients peri-procedure, they can have strokes. So these are a lot of rationale that is being involved in which the stroke, the cardiologist can come forward and share the burden. So we all know that cardiologists are familiar with treatment of dissections, sudden thrombosis and occlusion, which can occur with stroke intervention as well. They have the skills and knowledge of catheters, thrombolytics, stents, balloons, and snares. They are accustomed to making quick, thoughtful decision at any hour of the day. Middle of the night, we put in stents. So if the patient comes with stroke, they have all the expertise to deal with certain complications. Cardiologists, now this is the data of 2015 in the United States, and you can see among neurointerventionists, among cardiologists, and among, if you remember, if you include the radiologists as well, the graph is maximum for the cardiologists. So they're doing a lot of carotid intervention anyway, and which is considered to be an important aspect of stroke intervention, the learning curve of carotid angioplasty. So in the United States, maximum amount of carotid stent in 2015 was done by the cardiologist anyway. So the summary of pros, as I mentioned, is catheter skills, knowledge of therapeutics, knowledge of devices, availability at any hours. They have 24/7 primary PCI service running anyway, and these patients may already have a cardiologist. So what are the training? Now, training a cardiologist is just like training the horses, but for a different battlefield, because they have all the acumen, they have all the skill work, they have the hand available. So the ESC Council of Stroke or the European Association of Cardiovascular Interventions came up with a plan of training these cardiologists. So they arranged a course that is the local pre-training that has to be done, which is for proper assessment and selection of patients. This includes 100 CT angiograms, 50 MRAs, and 50 IVT assisted, and followed by hands-on training, that is 75 cerebral angiographies or carotid PTAs, and thrombectomies, which is 25 assisted and 25 performed. If a cardiologist can cover up all these things, then he is capable of doing independent intervention, mechanical thrombectomy. So this is the pathway they have progressed. This is focused education program in the form of X-Men course. It is 4 to 6 week course which runs either through modules, and it has got a clinical case as well as a practical case as well, and that is, and I'm very happy to know a lot of cardiologists from Pakistan are doing this case. This is followed by a simulator work to accelerate hand skills, diagnostic cerebral list within radiologist. Carotid stenting is very important, and this is already different courses are being conducted at RIC and also at different setups. And second operator and empty stroke first, and then the first operator, and then independent. So this almost takes about 4 to 6 months, training the horses for different battlefields, and they can come and contribute. So this is a study was conducted in Czech Republic, which showed how a cardiologist once who went through this pathway and started doing mechanical thrombectomy, and you can see the results are similar to that of a neurointerventionist. The TK3 flow was more or less the same achieved. The bleeding risk was more or less the same. Mortality was same. And the MRS at the end of the 1 year was more or less the same as it was performed by a neurointerventionist or a trained interventional cardiologist. So there's not much difference when it comes to the efficacy of the procedure and the patient outcomes. So the conclusion, there is enormous need for stroke interventionists. Cardiologists do possess the skills and understanding of the pharmacology. Cardiologists are accustomed to emergencies. All they need is training in basic neurology, anatomy, and a bit of skill and backup. The cardiologist can help with the logistic and share the burden. Thank you very much.
Thank you, Dr. Hamid.